Start. Good evening, everybody. Welcome you all to the day 3 event on Ventilator Graphics of the SK's Intensive Care Program. I'm Dr. Satya Prakash. I'm here today coordinating the sessions in place of Dr. Nishant. And before starting on today's sessions, a quick recap on yesterday's events. And we had 4 topics yesterday regarding bilevel positive airway pressure ventilations and weaning strategies, how to read a CT chest, and how to initiate invasive ventilations. Vinod? So regarding the carry home messages, regarding weaning strategies from Dr. Gopinathan sir, like when the patient is stable, resolving with low FiO2 and the PEEP is less, the saturations are maintaining with a good neuromuscular outcome and good neuromuscular functions, and stopping the sedations in between and giving adequate spontaneous breathing trials, and with the protocol-driven ventilator discontinuation process according to our institute's protocols. And regarding how to read a CT chest from Dr. Sivaprakasam sir, which was self-explanatory images, and regarding the BiPAP missions from Dr. Gautam Bandayar, and what he gave the messages like monitoring the patients frequently is very important while changing the settings on the BiPAP missions, and do not delay to ventilate the patient in case of any complications. And one more topic was from how to initiate the ventilator settings from Dr. Murli sir, and that was very, very excellent. And that's it. Okay. And regarding, we'll straight away go on to today's sessions. To start with, the first topic will be Dr. Vivekanandan sir regarding loops and scalars of the ventilator graphics. Screenshot, profile picture. And a short introduction of our speaker, Dr. Vivekanandan sir. Sir has completed his diploma in anesthesia from Jaipur in the year 1998, and he did his FRCA and EDIC and FFICM. And sir has held various positions as senior registrar in anesthesia and intensive care, consultant in anesthesia and intensive care, and as a clinical lead and various other positions in the United Kingdom from the year 2022 to 2015. And sir has been a senior consultant of the intensive care unit at KMCH from the year 2015 to 2018. And presently, sir is the senior consultant at the Royal Care Institute, Coimbatore. We welcome you, sir. And good evening, sir.
Good evening. Good evening, Dr. Satya Prakash. Thank you. Thank you for your kind introduction. Warm welcome to everyone, and greetings on behalf of Institute of Critical Care Medicine at Royal Care Hospital. We'll get started if I can share my screen.
Yes, sir.
Is the screen visible?
Yes, sir. We are able to view it.
Thank you. Thank you. At the outset, thank you for the invite to present at the Intensive Care Symposium, the workshop that has been organized. It looks wonderful. The topics look great. Thank you. Good evening, one and all. The topic for this session will be loops and scalars, and I've been asked to emphasize on PT scalar. So the overview would be, we'll touch upon scalars, a brief look at loops, because we have got speakers subsequently who will be detailing on different types of scalars and loops. And I would emphasize more so on PT scalar and few clinical scenarios associated with the PT scalar. So just a quick recap of how a mechanical breath would be delivered. So next few slides will touch upon that, and then go to the loops and scalars. So a mechanical breath is typically initiated, and how is it initiated, and what target is it aiming to achieve, and how the single breath ceases say for example, from inspiration on to expiration, how it cycles. So these are important things to know before we embark upon looking at loops and scalars. So a trigger is how a breath is initiated. And for instance, if it's a control mode, after a preset time, the breath is triggered. And if it is going to be an assist mode, then probably the breath is triggered by a pressure, or it can be a flow trigger as well. What it indicates here is the bias flow. It's actually a constant flow of gases that happens during the expiratory phase. And during the expiratory phase, if there is a diversion of this flow by the patient's breath, then that is sensed, and that causes a trigger as well. So in a spontaneously breathing patient, such a bias flow trigger can also act as a trigger. And what would be the target? So a preset pressure in pressure controlled ventilation, or it can be a preset volume, as in volume controlled ventilation, is what the ventilator is going to achieve. And once the target is achieved, then typically a cycling happens. Cycling, typically the ventilator will switch on from inspiration to expiration. So such a switchover is called a cycling, and this cycling will be time cycled, as in a pressure controlled ventilation, or it can be a volume cycled, as in volume controlled ventilation. These are pretty straightforward. What if the patient is having a spontaneous mode on a pressure support ventilation? Here, I think if you're going to think about the peak inspiratory flow and that drops to a preset level, then it would trigger the cycling process. So I dare not use this word trigger here, because it is the cycling that happens. So after that preset fraction of drop in the inspiratory flow happens, then that causes cycling from inspiration to expiration. So this is how a typical mechanical breath is working. So a scalar is a representation of different ventilatory parameters over time. So let us look at scalars, and the parameters that it looks at can be pressure, it can be flow, or it can be volume. And all these parameters are on the vertical y-axis, and time will be on the x-axis. So a single mechanical breath, say for instance, the parameter of pressure can be represented on the y-axis, and over a time period, how much pressure is being delivered will be represented over time on the x-axis. And typically, pressure and flow are measured entities, and volume is a calculated entity. I just want you to be aware of that. So we will look at the three scalars, typically the volume scalar, volume time scalar, the flow time scalar, and the pressure time scalar. So next few slides will take us through that. And if you look at the volume time scalar, they have got two limbs, the inspiratory limb and the expiratory limb. Both of them look similar, but the inspiratory limb is a upward stroke and the expiratory limb is a downward stroke. And the inspiratory limb and expiratory limb can tell us quite a lot of things. So if you look at it, just like a cardiac patient, if you're looking at the ECG, and that tells you quite a few details. So anybody on a mechanical ventilator, we should be looking at these graphs so that it can tell you quite a lot of information about the patient. Then examining the patient will tell more details. Then we can come to a conclusion that this is what the problem is, or this is how the patient is being ventilated, and is it adequate or not. All these details could be embarked upon. So I would make a similarity. If you're going to look at a cardiac patient, looking at a ECG is what is similar to looking at the ventilator graphs for a ventilated patient. So the expiratory limb for this particular slide, if you look at the expiratory limb of the second volume time scalar, it stops short of touching the x-axis. There it could possibly raise the possibility of leak or auto peak. So these are possibilities. So volume time scaler can tell you so many details, which will be dealt by Dr. Sunil Karant later. Then looking at flow time scaler, there are two different types depending on the type of flow. There are umpteen number of flows that can happen, accelerating flows as well, but within the context of ventilating human beings, I think these two flows are commonly used, the decelerating and the constant flow. And if the decelerating flow is used, which is typically in the pressure control ventilation or pressure support modes, and the constant flow that tends to happen in a volume controlled ventilatory mode, these are the scalars you would embark upon. The first one is the volume controlled flow time scalar, and the next one is the pressure controlled flow time scalar. And typically, one would advise that it is better to use a decelerating flow because the peak average pressure that tends to be achieved during the use of decelerating flow can be lower. That is the advantage of using a decelerating flow. However, the mean airway pressure tends to be higher. So we need to be cognizant of this fact. Using a constant flow, it can vary. So using a decelerating flow, the advantage is the peak airway flow, peak airway pressure, it tends to remain low. How about a flow time scalar? Flow time scalar can give up quite a lot of clinical entities if you observe by the bedside at the ventilator. It can tell you that the expiratory limb very well can show obstruction to the gas flow. It can very well delineate how severe the obstructive airway disease is, how difficult the ventilation is, or there could be instance of air trapping or auto peep that tends to happen. And the peak expiratory flow typically could increase with a decrease in lung complaints. So all these parameters can very well be displayed if flow time scalar is being monitored. Another example is this air trapping, where I would like to highlight this, where the expiratory flow showing that it does not reach the x-axis and it is falling short of it, showing that there is air trapping, and this could increase with subsequent breaths, and probably that could cause a hemodynamic imbalance as well. So that's something to notice by the bedside, and clinically you could arrive at a conclusion. So it can be giving away quite a few clues. And what is the third time scalar? That is the pressure time scalar. So typically with a pressure controlled ventilation, it is a square waveform, and with a volume controlled ventilation, it is a peak that surges and then has a sudden drop. And this pressure waveform is contributed by three different pressure components, which is by the airway pressure, the pressure to overcome the elastance of the lung, and by the peak end expiratory pressure itself. So a quick look at the pressure time scalar. If one has to look at the pressure time scalar during a volume controlled ventilation with the inspiratory hold, then we will be able to ascertain the peak pressure and subsequent plateau pressure as well. So you can see the upstroke where during the initial phase there is no change in flow or volume, and it is a straight upstroke, and subsequently with the increasing pressure there is volume that tends to increase, and it would reach a peak, and subsequently the pressure drops. That is the initial pressure to overcome the airway resistance. That much of a pressure would drop again, and then you're in a way you are looking at the alveolar pressure, and that would be depicted by the plateau pressure. So there is the airway pressure, airway resistance is negated, and you are looking at the alveolar pressure by the depiction of plateau pressure. So there would be instances where there is an increase in peak pressure or the plateau pressure, or it could be both of them. In certain clinical circumstances, it can be increased. And all these vital information could be given by the pressure time scaler. How about loops? So we have got two different types of loops. And straight away, let me highlight the fact that there is no time component in loops. Typically, the two different types of loops are pressure plotted against volume. The other one would be flow against volume. So again, in both these two loops, there will be the inspiratory and the expiratory phase in each of these loops, looking at a single breath, and the parameters will very well evaluate the respiratory mechanics that is being involved. So in this pressure against volume loop, you can see the inspiratory phase and the expiratory phase. And with the flow volume loop, the inspiratory phase is depicted above the x-axis and the expiratory phase is below. So just one need to be cognizant of how the inspiratory limb and the expiratory limb works in these two different loops. I'm not going to go into the details of this busy slide, the pressure volume loop. I think Dr. Ajit Kumar will later detail these loops. But meanwhile, I just wanted to highlight the fact that these can be quite extensively informative by the bedside, wherein you can look at lower inflection point, upper inflection point. Thereby, you could probably look at what the optimal PEEP for that particular patient could be. So it can give away quite a lot of information. So that is a pressure volume loop. And then the flow volume loop, wherein we looked at the inspiration is above the x-axis and the expiration is the curve that is below the x-axis, and depicting the peak inspiratory flow rate and the peak expiratory flow rate. So again, flow volume loop can be quite informative in many clinical situations on a ventilated patient. So this is a slide that is depicting the pathology that is being involved with a flow volume loop, and also a very simple pathology like airway secretions causing a sawtooth appearance, or the circuit leaking with a preemptive stoppage of the expiratory limb. So quite a few information can be gained by the bedside on the ventilator interface with a flow volume loop. So a brief mention about pressure time scaler. So let us have a little bit of a detailed look now at the pressure time scaler. So this is how a pressure time scaler would look like. Here there is the time component added to it. This is a pressure targeted mode where you've got a square wave pattern, and the top one would depict the peak inspirated pressure. And the one next to it would be the pressure waveform in a volume controlled flow targeted mode, where after overcoming the initial airway resistance, there is an increase peaking to the peak inspiratory pressure, and then a drop happens. Whereas the graph below depicts the inspiratory hold, wherein you see different parameters like the peak inspiratory pressure and the plateau pressure as well. Let's go into more details. So there are two maneuvers I would like to highlight upon, which is the inspiratory hold and the expiratory hold that you can do during a volume controlled ventilatory mode. If you do an inspiratory hold, then during the volume controlled ventilation, if the flow is constant, then probably you can come up with the details of the plateau pressure. And employing a decelerating flow in a pressure control mode will be useful to reduce this peak inspiratory pressure. So having inspiratory hold will tell us the plateau pressure. If you're going to have the maneuver of expiratory hold, then we can measure intrinsic PEEP. So intrinsic PEEP will be very useful for monitoring in asthmatic patients or airway obstructive diseases where the ventilation is difficult. Probably you're having an increased intrathoracic pressures that is adding up with every single breath, and it will be a useful maneuver if you do a expiratory hold, trying to ascertain what the intrinsic PEEP is. Over the next few slides, we will probably look at how this pressure time scaler will help us delineate the clinical situation. So for this, I think we will look at the equation of motion for the respiratory system. And if you were to think of this logic of the ventilator being a piston, and again, our own body system as another piston system working with the help of diaphragm, then you could come to this conclusion that the pressure that is being applied by the ventilator at any one particular time would be equal to the pressure that needs to be overcome, which is contributed by the endotracheal tube and the upper airways. So the pressure that is being applied, the pressure that is due to the upper airways and also due to the resistance by the endotracheal tube. So that would be contributed towards the PRES, that is over a fixed time. And then PEL would be the pressure to overcome the elastic force. So the elastic force of the chest wall and the lungs would be overcome by that pressure. So it is a total of the pressure to overcome the resistance of the airways and the pressure to overcome the elastic force of the lungs and the chest wall. So that would be the equation of motion for the respiratory system that the ventilator has to overcome to deliver a breath. So looking at a typical pressure time scaler, it is the initial, I would like to draw the attention towards the green aspect of this pressure time scaler. That would be the initial resistance offered by the upper airways. It could be the endotracheal tube or the upper airways of the lungs per se. So during that time, this much of resistive pressure is being added. Only then you would have the recruitment of the alveoli later, given by the upstroke and reaching the peak pressure. And this peak pressure will have a fall once the flow stops or no more volume is being delivered or no flow happens. That's when a drop in the pressure would happen. And this drop will be equivalent to the pressure initiated or exerted initially to overcome the initial resistance of the airways. And that time would equate to the alveolar pressure. So that would be depicted by the plateau pressure. So the small red line that connects time 0 to the point where the pressure drops from the peak inspiratory pressure down, there would be no airflow, there would be no flow of air, and that would equate to the alveolar pressure. And that is depicted by the plateau pressure. So this is a typical pressure time scaler. And we have seen the law of motion of the respiratory system, how the pressures are being added on, and that would be the pressure the ventilator overcomes to deliver the single breath. So let's look at some of the clinical scenarios, and everyone I'm sure would be aware of the mean airway pressure formula, which details the components that determines it. One is the flow, the other one is the resistance, then the contribution from the lung per se, the alveolar per se, for the unit change in the volume, for the pressure, and the compliance of the unit per se. So this will be a normal values here that are depicted here, where one would aim to keep the peak airway pressures to less than 40 centimeters of water. And ARDS dictates that probably if you keep plateau pressure less than 30, then there is even mortality benefit. And the respiratory airway pressure to be less than 10 centimeters of water. These are some of the values to go by. And the graph that is depicted here is a normal pressure time scaler. So we looked at the initial pressure that has to be overcome, then we reach a peak pressure, and there is a drop in pressure when there is no flow or volume being delivered, and that would equate to the alveolar pressure, which is the plateau pressure. And this single breath stops there. So that is the pressure time scaler and the components that are associated with it. And mind you, these are all square wave pattern flows that we are talking about. So what if the airway pressure tends to go up for multitude of reasons, be it bronchial asthma or a kinking tube? So the upper airway pressure is what we are trying to talk. And if there is an obstruction to the tubings, or there is increased resistance from the upper airways, then probably the initial pressure to overcome delivering the breath is high, and typically there is an increase in the peak airway pressure, and that would increase the peak airway pressure. But mind you, the initial resistance that is huge also drops when there is no flow or volume being delivered, and it would give a normal plateau pressure. So in this particular circumstances, I would like to compare with this normal graph on the side. And if you compare this pressure time scaler and normal graph to this, then the initial pressure that is exerted is high because of the upper airway obstruction. And once that falls, then the plateau pressure is quite normal. How about looking at the ventilator interface? That typically depicts you the same picture where you got a peak pressure which is high, but the plateau pressure is normal. And this is involving the square wave pattern of a flow. How about we have got another patient where we have dialed the excessive flow. The flow is very high. The graph itself looks pretty similar, but I would like you to focus on the time duration taken to reach the peak. That is lesser. So typically there is a shortening of the inspiratory time that tends to happen with the increased flow as against increased resistance. So the pressure time scaler will look like this when compared to the normal wave pattern, but the important discretion from the previous wave would be that there is a shortening of the inspiratory time. So just make a note of that. So with a high flow, there is a reduced inspiratory time, and the peak pressure is high and the plateau pressure is normal. And looking at a decreased lung compliance, the pressure time scaler would look like this when compared to the normal, wherein the resistive pressure seems to be the same, and that drop is also same, but the peak pressure is raised and the plateau pressure is also raised. So there is an increase in both the peak pressure and the plateau pressure. When the plateau pressure raises, automatically the peak pressure also increases. The typical example would be an ARDS patient. Again, here the pattern of the flow is a square wave flow pattern. This is the ventilator interface showing the same. The plateau pressure itself is gone up, and the resistive pressure, although it is less, the peak pressure has already increased because of the plateau pressure increase. How about the waveforms that might look like if there is going to be a decelerating flow pattern? So here, I think the flow patterns are slightly different, but the essence of how the depiction is pretty similar to what we observed in the previous few slides. So the one on the left top is the normal pattern, where there is a normal peak inspiratory pressure and normal plateau pressure. And when the airway resistance is high, the peak pressure goes up, but the plateau pressure remains normal. Again, if the flow is going to be high on the left bottom, the peak pressure again increases. However, if you look at the slope, how much time it has taken, the inspiratory time is shortened with a higher flow. Please do not make a note of it. And coming to the typical ARDS patient with a lower compliance, the plateau pressure itself is increased, thereby increasing the high peak pressure as well. So you would observe a higher peak pressure as well. So these are the waveforms you would see in a decelerating flow pattern. So with one more slide, I would come to conclude this talk. I would like to stress upon this, which is basically a stress index is something that you could ascertain from a pressure time scaler. And this is typically calculated from the ventilator. All it looks at is when the patient is having a flow that is maintained constant during a volume controlled ventilation, the rate of change of airway resistance is directly correlating with the rate of change of compliance. So if you look at these three curves, the one with a stress index of 1 in the middle, where the compliance is normal with the increasing volume, is a normal picture. But if the one on the top, where the stress index is less than 1, the compliance improves, the waveform with a upward slope, or the slope is slower, the one on the top, where the stress index is less than 1, the compliance will improve with the increasing volume. So that is even eyeballing by the bedside, eyeballing the ventilator interface will tell you that the patient can be recruited with an increasing volume. But if you look at the bottom curve, where the stress index is more than 1 and the slope is steeper, the compliance is low. So with a normal slope, it indicates a stress index of 1. When the stress index is more than 1, probably the compliance is decreasing. Just by eyeballing the ventilator interface, you can come to a conclusion on a flow time scaler. So having a look at this stress index is easy. You can even very well by the bedside come to a conclusion what the patient's status is. So the next slide tells you, based on the mode of ventilation that you've chosen, let it be volume controlled or pressure controlled or pressure support spontaneous breaths, the parameters or the waveform that you need to monitor in a volume control will be a pressure time scaler. Whereas with a pressure controlled mode, you could go for a volume time or a flow time scaler. So these are the different parameters which you need to be monitoring so that certain variables will vary and some of the variables will not vary. So one needs to be cognizant of that fact in a volume controlled ventilation. If you look at pressure time scaler, it can give you quite a lot of details. So just to summarize, ventilator graphics can provide real-time information, and pathologies like air trapping, auto-PEEP can easily be ascertained by the bedside along with the clinical picture. And if there is an increase in airway resistance or complaints, or subsequently contributing to the patient ventilator asynchrony, which will be dealt with later today, all these factors can be ascertained by the bedside using these scalers. So monitoring and assessing response to therapy is vital. Simple maneuvers like seeing a sawtooth pattern on these graphs can tell you that there are secretions, and suctioning the patient can very well relieve it. So it can be quite worthwhile looking at these graphs, which are real-time informations, and providing the appropriate therapy. Thank you. Thanks for the opportunity.
On, unmuted. Okay. Thank you, sir. That was a very clear and very engaging presentation, and all the depicted flow and volume loops diagrammatic presentation was excellent. So we have a question in the chat box from Dr. Anil Satyadas. Like, what would be the ideal flow rate to assess the trans airway pressures to differentiate resistance versus compliance problem?
Typically, we tend to have a flow rate of around 60 liters, 40 to 60 liters. But one has to be cognizant that individuals are different. So no one flow will be ideal for everyone. So I think probably you'll have to, depending on the pathology of that particular patient and the compliance being looked at on the different scalars, only then you could ascertain based on the compliance what would be right for that particular patient, what flow will be right for that patient. But I would suggest using this decelerating flow on the pressure controlled ventilation, because the peak pressures that is being achieved will be lower.
Okay. Thank you, sir. I hope that answered Dr. Anil Satyadas' question. So no, I cannot see any more questions. And anyway, thank you so much for your valuable time, sir. And it was really nice to have you with us. And
Thank you, Dr. Satyaprakash.
thank you, sir. We'll go on to the next presentation by. We go on to the next presentation by Dr. Sunil Karanth, who is the chairman of Critical Care Services, Manipal University, and head of the department and senior intensivist of the Manipal Hospitals, Bangalore. And sir's area of interest are trauma, neurocritical care, obstructive critical care, and extracorporeal therapy. And sir has held various positions like chair of HICC, member of Medical Advisory Board, and chair of Code Blue Committee, member of Pharmacotherapeutic Committee, chairperson of Bangalore chapter of ISCCM, senior examiner and teacher for IDCCM and IFCCM, and senior examiner for National Board Examinations, and a member of Karnataka State COVID Task Force and Critical Care Support Team. We are very happy to welcome you, sir, for this presentation. Over to you, sir. Dr. Sunil Karan, sir.
Yeah, thank you. If the chair can give me the host rights, please share the screen.
Yes, sir. We already given you, sir. You can share the screen, sir.
Okay, yeah, now it's coming on. Yeah, thank you. Thank you for the opportunity. I would like to thank the entire Salem team for having me on this program, and nice to see a great amount of participation already. You can see my slides, right?
We can see it.
Great, thank you.
Yes, sir, we can see it.
Yes. So my topic has already been made quite easy by the previous speaker, who has already touched a few of the points, and I'll just be probably reiterating a few points, and it will be on volume, time, and flow time scalars. Now, what do we mean by talking about scalars, and why is it important? So that's what I think it's already been repeated many times. So as we all know, one of the important things about ventilation is that in a high volume ICU, we see about 2/3 of the patient often who need ventilation, which means about 60% of the total number of admissions would require invasive mechanical ventilation, and then to 70 to 80% would require various forms of supportive care. So it's very important to know the nitty-gritties of how we actually manage manage a ventilatory patient. And many authors say that looking at ventilator graphics is something like looking at an ECG for a cardiac patient or an EEG for a neurotrauma patient or a neurocritical care patient. So I think that is the importance that is given to this this scientific knowledge that we gain. And it's also important to understand that a lot of our companies or ventilator manufacturers actually throw a lot of light on this, or throw a lot of effort to get these graphics on board. Of course, as we already are aware, there are two types of graphic displays. One is scalars and one is loops. Scalars is where we look at it in relation to time, and loops is in relation to two different variables. So why is this important is that we need to understand that it is important to pick up complications early. Sometimes there are signs or subtle sort of changes that happen on the scalars and loops, which help us to monitor for early detection of complication. Most importantly, to pick up ventilator patient asynchrony when the cycling is not optimal, when you find that there are the breathing is very erratic. This is where the ventilator graphics help, and of course monitoring respiratory mechanics. Most importantly, the trends of respiratory mechanics. So for somebody who is unaware or has limited knowledge of this and fails to use these ventilator graphics, it's probably what I would say as a sort of a blind sight, or just ventilating somebody with numbers without really having the knowledge of this graphic representation is probably not the most optimal way of ventilating patients. It gives a good idea of the changing status of the respiratory physiology, which is often the case that we see in many of our ventilated patients, especially who are having specifically a respiratory problem like ARDS, COPD, because these are all dynamic conditions, and we do find that there is a there is a sort of progressive, or the trend of change can be picked up early if we are aware or familiar with ventilator graphics. It's not a very difficult science to learn. It's a simple and a short, has a very simple and a short learning curve. So I think that is where the crux of the aspect lies, and it has a whole lot of advantages which we can actually come about. So very simplistically putting respiratory physiology, I think it's already been described. What we need to understand is when we talk about respiratory physiology in a ventilated patient, it is the entire system that we need to understand. So, the basic, what we call as the equation of motion is, of course, the amount of work done to overcome resistance, which is the pushing of air into the respiratory system and the tubings. Which of course has its own components of the flow, the bronchoconstriction, etc., and even probably the length of the tubing, which contributes to the dead space, etc., and of course the compliance. So this is what we call as the work of breathing, and we could represent this in a mathematical formula as we have on the right hand side column, on the right hand side of the picture. It can be in a pictorial format or it could be in a graphical format, and the graphical format of that is what we often represent as different kinds of ventilator graphics. Now coming specifically to the to some of the to the topic per se, there are two aspects when we talk about somebody who's being ventilated. You could have a fixed setting where the patient is paralyzed, and you could have a volume controlled system, which I'm sure all of you are aware of what a volume control is, or a pressure control system. So it could be what we call as controlled ventilation, could be volume targeted or volume controlled or pressure controlled. Now, in both these circumstances, if the patient is paralyzed and deeply sedated, there is no component of the patient's efforts coming in there. But it gets more complex when the patient's efforts start coming in, as you can actually see on this formula here, where you actually find that the green are the ones where the change to respiratory mechanics happen either as a part of the changing mechanics of the patient himself, or of the fact that there is efforts to breathe, etc. So this component changes whenever there is a change dynamicity in the disease. So the red component is the one where you find that it is quite static, which could be either pressure controlled or volume controlled. And in the setting of a pressure controlled setup, or in the setting of a volume controlled setup, you find that the volume part remains constant, but it is the changes that happen in the elasticity or the resistance which actually causes other changes in the patient in terms of the pressure changes, peak pressure changes. So when the volume is constant, you do observe that the pressure varies when there is a change in the elasticity or the resistance. But when the pressure is constant, you find that the changes actually happen when any change in the elasticity causes changes in the volume. So that is the fundamental difference between a pressure control and a volume control kind of a setting. Now, when somebody has addition of the patient's muscle activity coming in, that is when the picture becomes even more complex, and the situation changes from control to assist control, and lays the bedrock to actually cause possibility of a ventilator patient asynchrony if the patient is not breathing in tandem with the ventilator. Now, the steps to identify ventilator graphics, there are 5 or 6 steps that are described. I will not go into the detail of this because it's not the focus of the talk. But what I want you to understand here is that with the ventilator graphics or interpretation of ventilator graphics, it is important to identify certain basic things like identify the type of breathing, which could be controlled, assist control, or it could be a spontaneous mode. And in that, whether it is a volume control or a pressure control sort of a mode, which will also give us an idea of what are the different, to differentiate the different pulmonary measurements, and in turn help to actually understand what is the basics of the disease which is happening, whether it is an elasticity problem, whether it is a problem with the resistance, or whether it is something else which is happening, as the disease evolves, or as a sudden event such as a disconnection or a leak or something of that sort. Now, scalar has already been described by the previous speaker, is that it is nothing but a pressure, volume, or a flow wave, which is represented over a time axis. So that's a scalar. Essentially, we are talking about the three important parameters, which is pressure, volume, and flow, which is plotted against time, as compared to loops where you have either pressure versus volume or such other two variables which are coming, where time doesn't become a constant, or time doesn't become one of the defining factors for the axis. So in other words, when we talk about ventilation, whatever the different kinds of modes and different kinds of newer sort of techniques of modes of ventilation which the companies come forward with their marketing strategies, it is important to understand that fundamentally there are only three things which are happening: pressure, volume, and flow. It is the different dynamics of these three variables which determines the different kinds of mode. And of course, that in various combinations is what is we are going to do. And if you bring time as a constant into that, you're actually bringing in the whole concept of ventilation into it. And of course, based on that, as I said, there are different modes which we know about, and essentially it is playing with these three sort of aspects of gas flow, which is pressure, volume, and flow. Now, how are the scalars useful? They are one of the most simplest forms, I would say, of the ventilator graphics, because as I said, there is one variable versus time. So it could be pressure versus time, which the next speaker is going to talk, or it could be volume versus time, or flow versus time. Now, in my talk, it is volume and flow. Why both of them are connected together? Because there is a more sort of direct connection between flow and volume. In fact, in many of our newer ventilators, the volume is deduced from the flow rather than being an independent variable itself. So flow is very much akin to volume, and I think that is something we need to understand. That's why the flow and volume scalar almost always go hand in hand. So some of the uses of this is that it's a very simple, as I said, graphical representation of single variable, and helps us to give a trend of the changing patient's condition. So also to help detect problems early, even before the numbers change, so that you don't miss out on things. For example, early leaks, or there is new onset bronchospasm, prolonged expiration, auto peeping. You could talk about increase in pressure scalar, about gradually increasing peak inspiratory pressures, plateau pressures, which are increasing. So all these kind of changes that if you watch over a period of, or a trend, it makes you understand that whether there is a problem happening, or there is a response to a treatment that you have instituted. It also gives us an idea of what is the patient response to interventions, as I said, and a good overall representation of the lung mechanics, which is what we are ultimately very interested to know. And when I say lung, it may not be only lung, but it could be also meaning the airway. That's why I told you, when we talk about the respiratory system in a ventilated patient, it is the entire system, which is the ventilator, the tubings, any resistance on the way, like your HME filter, the patient's airways, patient's lung compliance, including the chest wall compliance. All these become a part of a system, and also helps us to adjust therapy. Now, coming specifically to the flow time scalar, the variations in the flow time scalar are largely determined by the mode of ventilation, as was already shown by the previous speaker. The shape in some of the times can be set by the clinician. So it could decide on, for example, a decelerating or a square waveform. So the flow time scalar does permit in certain ventilators, or in certain times, maybe not always, but in certain times, to determine the sort of flow characteristics to some variable extent, where of course the bias flow plays a role, your ramp, how the slope of the ramp or the ascending ramp plays a role, whether you want a square wave pattern, whether you want a decelerating pattern, all these does make a difference. And it also, of course, depends on the patient effort, and most importantly on the respiratory mechanics. So these are all factors which determine the flow time scalar. Now, coming the other part of it is, of course, the expiratory flow and the peak expiratory flow also will be determined in the flow time scalar, will be determined by changes in the lung compliance and airway resistance, which is nothing but the passive component of the respiration, and also when there is active efforts to inhale, and most importantly to exhale when we talk about obstructive airways disease. Now, the common clinical applications for the flow time scalar where I spoke a lot of theory till now, as you know, but where this can be applied in clinical practice is for early identification of airway obstruction, where you get a very prolonged expiratory limb on the flow time scalar, and you actually find that the next breath happens even before the complete emptying or before the expiratory limb touches baseline. I will show you the graphic later. It is also very useful in this context to understand the response to the bronchodilator therapy, so you have a obstructive pattern on the flow time curve. You start therapy and you again reassess whether there is an improvement or not. And of course, that is a good marker of what is called as air trapping. So you don't have to actually always look at the expiratory pause, or as you do in a pressure time scalar, to see what is the auto PEEP. But this is an indirect way to know that there is air trapping. Of course, you may not get a measure of it, but it does indicate that there is air trapping. On the other hand, the volume time scalar is probably relatively less informative, but it does give a good visual illustration of the inspiratory tidal volume. So, of course, you can measure the tidal volume with numbers which come on the ventilator. There is an inspiratory tidal volume, there's an expiratory tidal volume. The difference between the two, which gives you a rough estimate of the leak, etc. But it's a good sort of static or visual impression of the inspiratory tidal volume. It also gives an idea of the inspiratory phase when you correlate it with the pressure scalar, inspiratory phase, and most importantly the expiratory phase and the inspiratory time in the whole respiratory cycle. So it has a good idea of the what you call as the I ratio, though all those assessments are better done with the volume time scalar. Common clinical applications of the volume time scalar is most importantly to detect a leak in the system. It could be either in the circuit or endotracheal tube, or even for that matter, sometimes if there is a bronchopleural fistula. So basically what happens is there is incomplete emptying or incomplete end of the expiratory limb, and you find that there is a sudden cutoff, which means that the volume is not completely emptying in a normal fashion, and there is a leak which actually abruptly ends the expiration. So the volume of leak can also be determined by looking at the distance from the plateau to baseline. So in addition to looking at the numbers, which is the difference between the inspiratory and expiratory limb, we also have a good idea of that, or the extent of the leak, by looking at the distance from the baseline and the plateau. Now, this is a typical example. I have purposefully eliminated the pressure scalar on this. I'm sure the next speaker will talk about it, but the whole idea was to concentrate more on the volume and the flow time curve. But this is how a volume control ventilation flow time or flow scalar or a volume scalar would look. As you can see here, this needs no explanation, but if you look at the flow time scalar, you actually see that there is an inspiration flow plateau, then there is a cutoff, and there is a gap. Now, this is the space when the plateau gets set, and it gets represented on the pressure scalar as the inspiratory pause. So that is the time duration when you are actually able to get an idea of what is the plateau pressure in a patient on a pressure time scalar. But this is how the volume and flow time scalar would look on a patient who is on volume controlled ventilation. Now, coming to pressure control ventilation, generally it's a decelerating flow. With some adjustments, square flow can also be obtained, but deceleration flow is often what is obtained, and that is the de novo flow pattern for pressure control ventilation. As was already mentioned, theoretically, deceleration flow is supposedly better because of better gas distribution, and this is based on in vitro data in lab on using the deceleration flow pattern and looking at the air gas distribution. But having said that, there is no strong clinical data to support it or to show that it is better in terms of ventilation or such other thing. So, but certainly there is a theoretical advantage of using deceleration flow, and that is why the peak pressure and of course the fact that you have a limitation on the peak pressure, there is some degree of lung protection in that sense. But of course, volume trauma is not controlled in this kind of a setting. So this is the typical pattern of the flow and volume curve that we would see on a pressure control ventilation. So if you look at the difference between the flow scalar and the volume scalar, for this is volume control and this is pressure control, and you can see the difference between especially the flow pattern, where this is more of a square wave pattern in the volume control, and this could be more of a decelerating ramp pattern that you see on a pressure control. Now, using the advantage of both, we have what is called as a pressure regulated volume control, which is nothing but a pressure control mode. That's why you have a deceleration pattern, but there is a volume targeted or a certain volume that is achieved in the minimum possible pressure by the flow dynamics or the flow algorithm, which the machine detects or the machine kind of calculates and modifies the flow in such a way that the algorithm gets itself to get the targeted or the required volume in the minimum possible pressure using the characteristics of the pressure control ventilation. So essentially, a PRVC is pressure control ventilation with a volume targeted or with a regulated or a fixed definite volume. This is the characteristic of what we call as an APRV, where you find that essentially the ventilator cycles between two different pressures, and accordingly you see that there is a variation in the flow volume. So this is something like, some people, certain companies call it as B capital I PAP, wherein the ventilator cycles between two levels of PEEP, what is called as a high PEEP and the low PEEP. And if the patient is paralyzed, you end up getting what is called as the control. It behaves like a pressure controlled mode of ventilation. Now, coming to the spontaneous mode of ventilation, which is nothing but the pressure support ventilation, you find that this is the pattern. Now, note the difference here. Though this is a decelerating pattern on the flow, you find that the baseline is not touched because this is a flow cycled, this is not a time cycled mode, but this is a flow cycled mode, where during the phase of expiration, there is no inhalation or no inspiration taking place. So the exhalation or the ventilator cycles down to expiration or switches to expiration when the flow drops to about 25% of the peak flow. And that is exactly what is happening here. So you find that the baseline is not reached, unlike what you saw in the pressure control deceleration pattern. Whereas here you find that once the flow drops to about 25% of the peak flow, you can actually set it 25 to 50%. You can set it at various levels. You find that the ventilator cycles off to expiration. And this is typically a pattern that we see with pressure support. And of course, the volume control graph or the volume scalar is quite similar to the pressure control mode, but you find that there could be a variation in the IE ratio here. Now, one thing that we need to understand here is the inspiratory-expiratory ratio, or the IE ratio here, may vary from breath to breath in a pressure support mode because it is controlled by the patient, since it is a spontaneous mode, unlike that what you would see in a pressure control mode where the IE ratio is fixed and the IE ratio is always constant. So thus, as I said, it is possible to detect the different modes of ventilation by looking at the volume and flow scalar. And if you actually add the pressure scalar onto that, you don't even have to read what is the setting on the ventilator. It's often possible to pick up the mode of ventilation, which is the first step of detecting or trying to look at the graphic. If you remember the 6 steps that I showed you in the 3rd or 4th slide of my talk. Now, important thing to pick up, as I told you, what is called as auto PEEP, or in patients who have prolonged expiration, or in patients who have obstructive airways disease, the basic pathological problem or the basic respiratory problem there is with the exhalation. Because of the bronchoconstriction, you find that the exhalation time, which is generally passive, takes a very, very long time because of the fact that there is expiratory obstruction or obstruction to the exhaled gas. And that is what you see here, where you find that there is prolongation of the expiration. In normally what you would have seen is that you would find that the ventilator kind of comes here and ends and touches the baseline during expiration, which is a passive process. But in these patients, you find that there is prolongation of this expiration, and even before the next breath starts, or even before the expiratory limb touches the baseline, you find that the next breath starts. And this is the one which represents the fact that there is air trapping or gas trapping, and that with every breath, accumulating gas causes increase in the functional residual capacity, or FRC, causing worsening of the dynamic hyperinflation, and it has its own set of problems. So though I have told you that expiration is the main problem, if you get into the basics of mechanics of COPD or ventilating these patients, we also know that these patients have poor compliance because of the FRC increasing. They have difficulty in triggering the breath, etc. So that is a different sort of talk altogether. But the basic problem here is because of the expiratory prolongation, everything else leads to as a cascading effect, and that can be picked up by just looking at the flow time curve, where you find that the flow time, expiratory limb of the flow time curve doesn't touch the baseline, as you can see in this figure. Now, another important problem that can be picked up is leaks. As I told you, the important thing here, the scalar here, is to identify the volume scalar, where you find that the expiratory limb of the volume scalar doesn't touch the baseline, and it just tails off. And you might actually even find that there is a sudden cut here, which is indicating that the patient has a leak somewhere, or the system has a leak somewhere. This is the typical picture of how you can see. So it's hard to find it on the flow, or on the, you cannot find it on the flow scalar or on the pressure scalar, but you typically find it on the volume scalar, where you actually find that there is an abrupt cutoff, and you find that the rest of the expiration is just, there is a precipitous drop because of the leak. Again, as I said, the distance between the plateau and the baseline will give you an idea of the extent of leak, which of course numerically you can look at by looking at the difference between the inspiratory tidal volume and the expiratory tidal volume. In this case, as you can see, there's about 100 ml difference, which is there. It's about 1/3 of the actual flow. And typically here also you can see that the difference between the plateau to the baseline is about 1/3 of the total height of the volume scalar curve. The other problem that can be also picked up from by looking at the flow time scalar is the presence of secretions or water in the circuit, which often reflects as sawtoothed appearance in the flow time curve, particularly in the expiratory limb. But if it is a lot, you can even probably see it in the inspiratory part of the flow time curve. So this is how typically, as you can see, a sawtooth, irregular kind of limb, that is the irregular sort of pattern that is there in the expiratory limb. So in conclusion, between the flow time and the volume time scalar, probably flow time scalar is more informative and picks up problems in more number of clinical scenarios. But there are one or two places, as which I already told you, that volume time scalar does have a role to play. But in combination, the flow time and volume time scalar do help us a lot. But it's always good to have the pressure, flow, and volume time scalar in one screen, and that will really give you a good idea of, or a basic idea of, what is the problem, what is the mechanics of the lung, is there a new problem happening, etc. In terms of inspiration compliance of the system, any expiratory issues. And the most important that we need to understand is that the trends are more important than a single point or a single stat picture. Thank you. I'll be happy to take any questions.
Online, no? Online. Thank you, Dr. Sunil Karan, sir, for the thing on flow time scalars and flow time and volume time scalar. We have a question.
Yes, please.
Question. Question.
An active inspiration due to
No, chat box, please. Chat box only. Just a second, sir.
No worries. Is that the question? Can active inspiration due to high patient rate have a similar picture?
Yes, sir. Yes, sir.
In the volume time scalar? Sorry, I didn't get the question. Can active inspiration due to high patient rate have a similar picture of leak? Not really, because the leak, see, in active inspiration, what happens is you actually find that there is a negative deflection. So to call it active, this thing, you have to actually compare it with either the flow trigger or the pressure trigger when there is a significant negative deflection. Here, the cutoff is more at the level of the expiratory limb. So therefore, it's quite easily picked up when you actually have an expiratory limb leak. That is, when you actually have a leak, which is a little different from the active inspiration that we talk about.
Okay. Thank you, sir.
Thank you.
Thank you so much. Thanks for giving us your valuable time, sir. And it was a very clear and very informative presentation. Thank you so much, sir.
My pleasure. Thank you very much. Yeah.
So now we'll go on to the next presentation on pressure volume and flow volume loops by Dr. A.K. Ajit Kumar, sir. A small introduction of the speaker. Dr. Ajit Kumar, sir. And he's a senior consultant, a head intensive care unit of Aster Whitefield Hospitals in Bangalore. And sir is a secretary-elect and in the Indian College of Critical Care Medicine, past accreditation secretary and past chairman of Indian College of Critical Care Medicine and Indian Society of Critical Care Medicine. And sir is a accredited teacher and examiner for DNB, FNB, IDCCN and IFCCM courses in the Bangalore chapter, and organizing co-chairman for Critical Care 2015 recipient, Presidential Citation Award of ISCCM 2015 and 2023 as reviewer. And Sarah has got various publications in the Indian Journal of Critical Care Medicine, Lancet, and eClinical Medicine. Profile picture. And BMC Pulmonary Medicine, Indian Journal of Surgical Oncology, Arthritis Care, and Indian Journal of Case Reports. And Sarah is an editor and past editor in Journal of Acute Care, and editor Star Pearls Medical Education Database in USA. And sir is a life member of ISCCM and ESICM. And we are happy to have you with us, sir. Dr. Ajit Kumar, sir. Over to you, sir.
Can I share the screen?
Yes, sir.
Yeah. So there's a little bit of, whatever you read there, there's a little bit of mess up is there anyway, that is irrelevant. That's fine. That's fine. Yeah, that's fine. Yeah. So yeah, I was the past whatever the chairperson of Bangalore chapter, ISCCM Bangalore chapter, and that's fine. No problem at all. Yeah. So basically the topic is the pressure volume and the flow volume loops. So Dr. Vivekanandam and Dr. Sunil Karan has already discussed about the scalars in detail, and some kind of overlap also has happened. So here this is going to be a very simple presentation because just stressing on only the practical application of these loops. So today's agenda, I will be just brief general introduction to the loops, and then it will be followed by I'll just discuss about about pressure volume curve, and the clinical utility of pressure volume curve will follow. Then a brief introduction to flow volume curve and the clinical utility, and finally the take-home message. So basically, Dr. Sunil and Dr. Vivekanandam has discussed about the scalars. So in scalars, what's happening is that in contrast to plotting the variation of one variable parameter against time. So what's happening in the previous one? There's a pressure time curve. Pressure is a variable, and it is plotted against time. And flow time curve, the flow is again another variable, and then it's against time. And volume time curve, volume is a variable. So one variable is against plotted one time. So here what happens, unlike that thing, the loops are basically, there are two variables are plotted against each other. So that is some kind of a dynamicity is happening in the graph. That is the importance of this. And obviously it is useful, we'll be discussing. So loops are therefore two-dimensional representation of the interaction between the two parameters selected, unlike the previous one we told. And in clinical practice, information obtained from the pressure volume and flow volume loops are useful. So basically, these loops are very much useful. I would like to say that if I can borrow Dr. Dr. Samavadam's words, basically, these usually the pressure time curve and the flow time curves are very, very important. And the loops, maybe we can always discuss, we can have some information, but how much it is going to be useful, I think that we need to, interpret the reports as per, the individual clinical situation. So this is the pressure volume loop. You can see that the pressure is there. This is the pressure is varying, and obviously the volume is also there. The pressure is plotted on the, the x-axis, and obviously the volume is on the y-axis. And this is the inspiratory part. When the patient is on a mechanical ventilator, this is the inspiratory part. It will be, the loop will be moving in the, basically will be moving in the anti-clockwise direction. So this is the inspiratory part, this is the expiratory part. So the volume is plotted on the y-axis, which I already mentioned it. The volume is here, the pressure is here, pressure on the x-axis. The inspiratory curve is upward and expiratory curve is downwards. That's very important. This is the upwards. It will be in anti-clockwise, and when the patient is on a controlled ventilation, like a mechanical ventilation, the spontaneous breath go clockwise and positive pressure breaths go counterclockwise. So mechanical ventilation, positive pressure breath will be anti-clockwise, and the spontaneous breath will be clockwise. We already mentioned. And the bottom of the loop will be the set peep, which we will be discussing. It will be zero. There is no peep set at all. If an imaginary line is drawn down the middle of the loop, the area on the right represents the inspiratory resistance, which I'll be showing in the coming graphs, and to the left will be the expiratory resistance. I'm just coming to that. So basically, these are the classic, pictures, which is, in textbooks and all. So basically, this is the pressure volume curve. This is in a patient who is having a spontaneous, the positive pressure ventilation. You can see that it is this inspiratory part, this is the expiratory part here, and this is this part, the inspiratory part is represent the inspiratory resistance, and expiratory part is representing the expiratory resistance. And when you have an assisted mode, what is happening is the patient is triggering. Whenever you can see this is the positive pressure ventilation, it's all positive here. But here, if you look at that, you can see that there is a negative deflection here because the patient is again different. This is immediately followed by a positive breath is there. You can see that it is just going up, and the inspiratory limb is it is just going up and coming, and it is going anti-clockwise. The expiration is coming down. This coming downwards, and when you come to spontaneous breath, naturally you see that the entire thing is starting the negative thing. This is the negative aspect of the graph. So this part is like the inspiratory limb is going up, and the expiratory limb is here, and it is going clockwise. So when the patient is having spontaneous breathing is going clockwise. When the patient is having a assisted breath or controlled breath is going, this movement is going to be anti-clockwise. With just an introduction about the structure of the curve. And when you look at that a little bit more closely, you can see that this curve is based on the FRC, the functional residual capacity. You can see this is the FRC. From the FRC, there is whatever the air is remaining already in the lung is there, and this is the graph is the curve is starting. And I would like to say that just for information, apart from the pressure time curve, this is the only whatever the loop, one of the only respiratory graphics. That is, this is the form of loop. The pressure time curve is the form of a scalar, which is in a depicting peep. So peep will be, as already mentioned, will be here. It will be starting the peep. If the peep is zero, everything will just, the entire graph is going to be here. This is the only curve, only another graphic apart from the pressure time curve, which is a scalar. This is a loop. This is a loop which is depicting the peep into the picture. So this is again very sure this is the inspiratory limb. This is the expiratory limb. We know that. Another thing we should be very clear. We should understand is that lung is not a pure elastic structure. We'll come to that. So during inspiration, you can see that obviously this is the pressure is changing here. The veiling pressure, this is the change in volume is happening. When you come to expiration, you can see that even with a lower pressure, for the same pressure, the lung can have, at some stage, lung can have more volume than, you can see that the volume can be more for the same pressure during expiration. So that means it's not a very purely elastic structure. The inspiration, expiration, the volume return and various pressures, definitely varies. And, this is, again, the curve again, this again introducing, you can see that there is something called the inflection points. Inflection points are the point whenever, these kind of a loop is having, significant change in direction. You can see that this part, this is the lower inflection point, this is the inspiratory limb of the thing. You can see that the direction is completely changed. This, change of direction which is happening is the point we call lower inflection point. And you can see in the expiratory curve, there is another called upper inflection point. The third inflection point, I'm used to that, but this is the upper inflection point. The importance of the lower inflection point is that it is believed that it is believed that the optimal peak is just above the lower inflection point, which is again highly debatable. So the lower inflection point is now theoretically speaking is a little bit important because this is the lung is like a balloon. You can compare with the balloon. you can see that when the balloon is fully deflated, when the balloon is fully deflated, it is difficult to inflate the balloon. But when the balloon is already having a little bit of PPR, whatever, a little bit of PPR, naturally it may be balloon is partly inflated, a little bit inflation is happening, then it's easy to inflate the balloon. So basically, the same principle, actually, you open the lung and keep the lung open by the PEEP. So this is the sudden changes happening. Suddenly it is easy to inflate the lung. That is the importance of this. And obviously, it's all theoretical importance, which I will be discussing in the coming the slides. So again, we already mentioned multiple times. This is the inspiratory curve. This is the expiratory curve. This is the obviously the pressure and the volume is depicted here. And the dynamic compliance, we all know that this is not only taking into account the airway resistance, it's also the elastic resistance as well. Consider the dynamic compliance. And looking at the curve, this particular blue, whenever it's a volume control mode, the pressure control mode, you can see that it may be square shape because the pressure is the pressure is same here. So naturally it may be looking like that. So whichever mode it is, they're also important, because when you just look at the curve, you see that whichever the mode it is, in pressure control mode, so naturally the pressure is going to be same, it is going to be flat here. The volume control, it may be the other way around. So this is just a closer look at the loop, that's all. And coming to the use of this one, the pressure volume loop, it is said to be useful for lung orbit distension and airway obstruction, bronchodilatory response, respiratory mechanics, Volkov breathing, etc., etc. So I will be just showing some of the practical application of the pressure volume loops. So this is a pressure volume loop in a volume targeted ventilation. So here what is happening is that the volume is going to be the same. The volume is going to be the same. So you can see that depending on the compliance, which is increased, normal, or decreased. So when you say that the volume targeted ventilation, the compliance is increased, means this is the compliance where you can have the highest volume. Sorry, the least pressure. The pressure will be the least. So basically, when the patient is a volume control mode, when you say that the volume is targeted, the volume is same. So what is happening is that if you say the compliance is increased, means the pressure level will be less. So when the compliance is increased, so naturally this is the normal loop here. You can see that when the compliance is increased, the pressure volume loop will be deviated to the left side, When the compliance is decreased, so naturally when the compliance is decreased, you can see that the pressure is going to be up. You can see that this is the pressure here. In the same volume, this is the pressure here. So naturally it will be deviated to the right side. So this deviation will happen. This is the volume targeted ventilation where the volume is constant. Even the pressure targeted ventilation also, you can see that when the pressure is same, when you say that the compliance is best, means this is the compliance where you get where the volume will be the highest. So you can naturally see that the volume is highest here. Again, in this situation also, it will be, when compared to the normal graph, it will be turned towards the left side. And when the compliance is decreased, it is going to turn towards the right side. This just because of the difference in the volume control mode and the pressure control mode, these changes are this minor change in the configuration is happening. And inadequate sensitivity, because I never been used to this. I mean, so it has been told that this way, the fish, whenever the patient is taking some kind of a trigger attempt is happening. So this kind of a thing. Whenever these areas are going to be more, this shows that there is a lot of inadequate sensitivity. There is a high trigger is there, increased Volkov breathing is happening. That is what does it mean? The more it is towards the left side. That is what is meant by that. And obviously, it is supposed to be, looking at the graph, it is being claimed that, because I don't have any sort of a real-time experience with this, you can look at the limbs, both limbs you can compare, and when you have a significantly low limb on one side, you can see that there is some kind of a inappropriate, this is inspiratory limb, we know that. The inspiratory inappropriate flow is on the inspiratory limb, and expiratory limb may be normal. Some kind of active inspiration, this kind of a graph has been described in the books. And this is the part of the graphs, because whenever you have an increase in the inspiratory resistance, you can see that this part is bulging. The expiratory resistance is more mean this part of the expiratory part of the graph will be bulging. So the expiratory resistance will be increased predominantly because of secretions, bronchospasm, etc. The inspiratory resistance may increase. It is just due to ET tube is too small, king tube, patient biting the tube, etc. So this is again one more use. But most of the time, these information we know that we can get from the pressure time curve. We know that when you have an obstruction is there, what is going to happen is the plateau pressure is going to be normal, will almost remain the same, and the peak pressure is going to go up. So naturally, the difference between the peak pressure and plateau pressure will be, significant. It will be increased, as mentioned by Dr. Vivekanandam, and Dr. Sunil. And this is another, a classic, exam. I will say the exam point of view, this kind of a classic, the pressure volume curve. You can see that in this point of time, for each pressure, the volume is, slowly increasing here. You can see that at some stage, even if you increase the pressure, there is the final volume has already reached. Basically, there is a flattening. There is no changes not happening here. This is called beaking. So this means that, the lung cannot accommodate any further volume. This situation is happening in a volume control mode. Maybe you might have to reduce the volume. You have to try to reduce the volume in this kind of situation. If it's a pressure control mode, maybe you can try to reduce the pressure, maybe, that may be trying to see that it is just going to some kind of a, water trauma sort of situation here. So this is, this is called the beaking of the pressure volume curve. And the same thing is depicted in another graph. This is again over distension. You can see that this part is, just beaking or, plateauing. This is again one classic description. It has been, many exams will be directly asked there. This is the inspiratory, the limb of the pressure volume of this expiratory limb. So the inspiratory limb, obviously during inspiration, it has been delivered to the patient, but some kind of a leak has happened to the patient in the between. And obviously when it comes here, the volume time pressure volume curve is not able to touch the baseline here. So it's not here. So that means there's a leak is a very classic, questions in the exam. Apparently there is a leak is there. And when it's not touching the bottom, like it is coming that it's not touching the bottom like this. Sorry, this is for the leak. This again in the air leak, it is not touching the bottom. This is the air leak here. And now we are coming to the flow volume loops. So pressure volume is, we just mentioned that the flow volume loop is, the flow is plotted on the y-axis and the volume on the x-axis. This is the flow here, this is the volume here. And flow volume loops are used for ventilator graphics are same as one used for pulmonary function test, but usually upside down. See, whatever you see in the PFT, regular PFT, conventionally, this is upside down sort of thing you see in the ventilator graphic. What I mean to say that the inspiratory part will be in the upper part and the expiratory, the graph will be on the lower part. This part will be inspiration, this part will be expiration. So we already made inspiration is above the horizontal line, expiration is below the line. The shape of the inspiratory portion of the curve will match the flow wave pattern, because obviously if it's a constant flow, it may be flattened like this. Flow is constant, but obviously in the pressure control mode, it may be decelerated flow, it may be just triangular, it may be just like that. I will be showing in the coming slides. The shape of the expiratory flow represents the passive exhalation. This is the passive exhalation. So can be used to determine the peak inspiratory flow, peak expiratory flow, and tidal volume. Look circular with spontaneous breaths. The flow volume will be circular and spontaneous. This is the inspiratory curve, this is the expiratory curve here, this is a peak expiratory flow rate here. And this is the beginning of the inspiration here. Again, we are just coming closer to the graph. This is the beginning of the expiration here. There is a peak flow which is here. And we already mentioned that when the flow is constant, this can be like it can be flat like this, very constant flow here. When the patient is on a pressure control mode, it may be decelerating flow. So this again can be used for so many things: air trapping, airway obstruction, airway resistance, bronchodilatory response, etc. But see, I believe that bronchodilatory response can be best seen, the flow time curve, which is very, very obvious. You can see that the peak expiratory flow is going to be, the flow time curve will be more, the expiration is more prolonged, and the peak expiratory flow is going to be more in the patients having severe bronchospasm. Once you give the nebulization, what will happen is that the peak expiratory flow is going to be high, and the exhalation time is going to be shortened. But even this graph, this loop also can be used for almost for the same purposes. The flow volume loop, this is this again another classic flow volume loop. You can see that this is touching the bottom before touching here. So that means there is there is a leakage which is happening here. There is a leak which is happening here, so it is not touching the bottom here. So after the inspiration, there is a leakage, so the all there which has been given to the patient is not exhaled. So it is touching the bottom a bit earlier. It should have touched the bottom like this. We know that. And when if it do not touch the bottom like this, it can be just show that some kind of air trapping. Just like the flow time curve, it is not touching the bottom. We see the gap is here. That same gap is happening here as well. So again, another picture. And you can see that when you have a severe obstruction, what is going to happen is that this is the normal flow volume, the flow volume loop. You can see that this is the inspiratory part, this is the expiratory part, this is a normal peak expiratory flow here. You can see that in this condition, when the patient is having severe obstruction, you can see that the peak is reduced. Not only that, there is a scooping is happening. It is supposed to be very characteristic of severe airway obstruction. That is what is depicting. the peak expected flow is low. And the flow is also just going to be really slow. It is not you can see that it is not very straight. It is slow and scooping kind of a flow is happening in a severe obstruction. This air obstruction is happening. And the same thing is depicted here. You can have normal flow will be there. It's a slow and scooped flow is going to happen, when the patient is having significant airway obstruction. And even when you have a lot of secretions, predominantly you can see that the expiratory part, there's a lot of turbulence. You can see in the expiratory part, it can be indirect evidence that there are a lot of secretions in the system, the tubing system, the ventilator tubings. So this, I think, just for the teaching purposes, I just taken some information from Essentials of Ventilator Graphics by Dr. Deshpande, Dr. Vijay Deshpande. And another from Dr. Charles William, and another from Dr. Ram Rajagopalan's book as well. So my message is very clear. The loops are two-dimensional representations of the interaction between two variable parameters. Unlike the scalars, which is a one-dimensional thing in the sense it is a one variable. Here in loops, what's happening? There are two variables are there. Unlike in scalar, which is only one variable is there against time. Here it is two variables are pitched against each other. They are plotted against each other. The contour of the loops can vary in relation to the mode of ventilation, pressure target or volume target. We already mentioned. We already showed in the graphs. Pressure volume loop is the only loop which I already mentioned where the PEEP is depicted in ventilator graphics apart from pressure time curve. So as far as my understanding, whatever all this my reading, this is the only this is the only ventilator graphics apart from the pressure time curve where even the PEEP is also depicted in the picture. The pressure volume loop helps in the identification of change of compliance on the basis of loop position in relation to the normal position of the loop. But you can see that when the patient is having increased compliance, it will be towards the left side. When the patient is having a decreased compliance, it will be turned to the right side. We already mentioned that. And the inflection points are the points on pressure volume loops where there is a sudden change of direction happens. The optimal PEEP is believed to be just above the lower inflection point. I think it's a big controversy because even though the optimal PEEP is said to be above the just above the point, but studies have shown that the pressure volume loop may not be really helpful because one reason is that many observation studies have shown that for many ventilators because of some various reasons, technical reasons as well. The proper pressure volume loops are not obtainable. That's number one. There's an issue with reproducibility of the pressure volume loops. Reproducibility is also an issue. Second thing is that studies have shown that if you use the studies using CT scan and many physiology studies have shown that in fact the optimal PEEP is well above the lower inflection point. That is another thing. So basically that is one thing. And another thing is that another thing is that there is no study which has shown that if you just the most important thing is that none of the studies have shown that if you try to titrate the PEEP for that matter any system anywhere, if you try to titrate PEEP as per the lower inflection point, it is going to make any better than the clinical outcomes. So basically, though it has been very seriously considered, but but many people believe that it just shows some recruitability of the lung. They believe that if you can get a proper pressure volume loop, the lower inflection point is very clearly seen in your graph. That shows that in that particular patient, the ARDS probably is more recruitable. If the lower inflection point is not very well seen, that shows that the lung is unlikely to be recruitable. So basically, the pressure volume loops, rather than trying to explain the optimal PEEP, it may be helping to find out the recruitability of the lung. That is what it is there. I'm just borrowing from an article by Dr. Ram Rajagopalan, maybe around 10-11 years ago. The flow volume loops help in the identification of air leak, air trapping, airway obstruction, and secretion in the circuit. Thank you very much for your patient listening.
Yes, sir.
Oh, sorry.
Yeah. Thank you so much, sir. That was. I hope the audience really enjoyed your presentations, and that was very nice, sir. And we really appreciate you, the time you took for us in spite of a busy schedule to be with us, sir. Thank you very much, sir.
Thank you. Thanks.
The next topic will be on patient and ventilator asynchrony by Dr. Kandasamy Subramaniam, sir. Sir has completed his diploma in anesthesia and MD anesthesia, and he did a FAR-CA from the Royal College of Anesthesia in the year 2000, European diploma in intensive care in 2003. And sir has got nearly 42 national and international publications under him. And right now, sir is the intensive head of anesthesia and critical care at CMC Vellore. Over to you, sir. Okay. So in the meanwhile, I just want to discuss with you. Recently, we had a case of difficult airway. So I just want to share with you what happened on that night. So it was in the middle of the night, around 2 o'clock or something. We had a patient. He was a 64-year-old man. He was operated for carcinoma, facial-maxillary surgery, and it was a post-operative. He was a post-operative case, I think third or fourth day. And suddenly they called. There was a call, emergency call, saying like he was not okay and he was having breathlessness. So when we went and saw the patient and he was not okay, saturations were around 62 to 64%, and GCS was very low. The GCS were around 6 to 8. So immediately we shifted the patient to the intensive care unit. So when we took an ABG, his PCO2 was around 82 millimeters of mercury. So we got the consent from the relatives. We explained them, and we immediately planned for intubation. So I just wanted to, but it was an anticipated difficult airway in the middle of the night. So very difficult to get someone to help you also. So somehow we managed to get somebody on board, and we tried intubating the patient without any relaxant, using fentanyl and etomidate. We just did a chexoscopy and nothing was visible because all the soft tissues were so edematous and very, very difficult. Even with an ambuscope, with etomidate and fentanyl, we tried with them, but we were unable to visualize the glottic opening. After then, in spite of interrupted desaturations, we were bag valve mask ventilating him with 100% FiO2. We were able to attain a saturation of around 88 to 90%. So we kept on doing it for the next 40 to 45 minutes, but somehow he sustained it. His saturations maintained in between. He had some desaturations and bradycardia in between, but somehow we managed to get him. And there was a final attempt of video laryngoscopy. Then somehow the consultant anesthetist at that time, he introduced a bougie into it, and just blindly it went inside the larynx. So we were lucky on that day, but nothing happened. We just wanted to share it. It was a complete team effort on that day. And even with the fiber optic or ambuscopy, we were not able to visualize his glottis at any point of time. So it was so edematous. The next point, we were trying for a scalpel cricothyrotomy or an emergency tracheostomy, because we had the ENT surgeon also with us. We called him up and he was with us all the tracheostomy. So this was a case that happened last week back. So just wanted to share it in the meantime. So
I think the decision made by you not to relax the patient actually saved the patient, right, sir?
okay, yes. We planned not to relax him at any point of time, Nishant. Yes.
So actually anticipating the difficult airway, sir rightly took a call not to relax, because has the patient been relaxed, definitely we could not have saved that patient that day. Post radiotherapy, upper airway edema, it was fully boggy. It was purely that decision actually made the patient survive for next 1.5 hours till we were able to put the tube inside the trachea. So that was really a nightmare. So any other, from your vast experience in past few years, any other difficult case you've gone through in OT, sir, apart from critical care? So that some take-home points like not to relax if you anticipate a difficult airway, give off some sedation and induction agent and then go off like that. Do you have any other take-home points, sir?
Yes, sir. Actually, we had many cases in the unanticipated difficult airway. We never ever anticipated the airway to be so difficult in those patients. So luckily, in those cases, we were able to ventilate them with a bag and valve mask ventilation. We were able to ventilate them, and few patients we were able to do it with an intubating LMA. And there was one case scenario who had it was in the casualty a few years back. He was a young guy, 30 years guy, who had some injection, some painkiller outside. Then he came to the casualty with a wheeze, and he had some anaphylaxis. And within minutes, and within few minutes, like he became the tongue is swelling up, and the airway is edematous. He's having absolute stridor. So we were not able to, like, we did a laryngoscopy, we were not able to visualize the glottis, and slowly he's getting bad, he's desaturating also. And that was that incident, that was in the casualty, actually, not in the operating room. We did a scalpel cricothyroidotomy. It was exactly, I think, 3 or 4 years back. In our SKS hospital casualty, we did a scalpel cricothyroidotomy with the same 6-size tube. Luckily, the tube went in. We were able to save him. We were relieved when we saw his chest rising up with 100% oxygen. His saturation was also improving. He was a young guy. We were able to save him actually on that day. And after that, we had a surgeon there, and he did a tracheostomy also after that, because we didn't want to prolong the scalpel cricothyrotomy after that. So within 1 or 2 hours, we did a tracheostomy for him. So that was one instant where this young guy was saved. And in the operating room, I have never come across a CICV till now.
Yes, sir. That was great, sir. So apart from that, I don't think.
I think they have many seniors here, many senior professors, and great people here who can share their thoughts with us. They would have been much more experienced than any of us here.
Definitely, sir. Definitely. So,
okay. I think Nishant Dr. Kandasamy sir is online.
Yes, sir.
Can you hear me?
Yes, sir, we can hear you, sir.
I'm really sorry. I'm trying in multiple this thing. I'll just open I'm just in the process of opening my presentation. Okay.
We're able to see your screen, sir.
Okay, is it visible, my screen?
Yes, sir.
Okay, sir, you take over, sir, please, sir.
Yeah. Okay.
Yes, sir, we can see it, sir.
Okay. And good evening, everybody. I'm really sorry for this hitch. So today we'll talk about ventilator asynchrony. I made to understand that some basics of mechanical ventilation has already been dealt with. So I am not going to go into the basics. So we'll straight away go on to ventilator asynchrony. Okay. This is CMC Vellore. If you've not been, this is the old hospital, and this is the new building which we moved into 6 months ago, which has a a quaternary care center, and we have ICUs in both areas. So the most common cause of delay in ventilator weaning is patient ventilator asynchrony. So there is a mismatch between the patient's effort and the ventilator cycle, and this happens mostly during assisted ventilation, but it also can happen during one of the mandatory breaths, which is assisted. So if you look at it, about 11% and 24% of the patient have frequent asynchrony, and very, very, very frequent. And because we don't keep adjusting the mechanical ventilator all the time. So if you look at the variables in a breathing, you have the inspiration, expiration. So this is how it proceeds, and each phase of the ventilation has, the inspiration is a trigger, limit, and cycle, as it would have been discussed previously. And problems can be anywhere in the expiratory cycle or the inspiration during the trigger, during the limit, or during the cycling period. So just to recap, so this is a typical flow, volume, flow, and pressure graphs, and at point A is the beginning of inspiration, and that is the trigger, and B is the limit, and C is the cycling, where the inspiration cycles to exhalation. If you look at it, it'll be easier to understand the asynchrony or pick up asynchrony if we have an esophageal pressure monitoring, where you can detect the patient's effort by a negative deflection in the esophageal pressure wave. But unfortunately, we don't use it, and we go by the waveform, the deflections in the flow, and deflections in the pressures and the volume. So the asynchronous can be classified as the first thing is a trigger asynchrony. So it could be an absence of patient effort, but the ventilator actually gives a breath. So patient is actually not breathing, but the ventilator goes ahead and gives the breath. So if you look at the expiratory wave, so this is the normal, the dark green is the normal wave. There is an exponential decay. Initially, there's a peak expiratory flow, and then it decays slowly and reaches the plateau. But you may see when you examine the expiratory wave like this, which means there may be a irregularity on the way, which may be tracheal secretions or sometimes water in the tubing, or it could be very regular like this, which may be a cardiac oscillation. So this is a figure where you see a lot of, the lines are very, very irregular. And if you look at this, this is actually a real-time motion picture. And if you look at this, then there is a lot of irregularity in the baseline waveform. And what you need to focus is that the set rate is about 10, and the frequencies here it is about 26. And if you look at actually the patient and the ventilator, you may see that the patient is actually not taking a breath. These oscillations cause change in the pressure and change in the flow in the ventilator tubings, and actually that triggers the ventilator. So this is a form of auto triggering where the ventilator delivers a breath without the patient making any effort. So this is a typical, when you have an active humidifier, you can see this. When the water slowly fills and forms a continuous, when it makes a continuous column, it vibrates back and forth, moves back and forth, which causes pressure changes and flow changes and causes the changes in the graph we saw, and it triggers the ventilator. So the next is the cardiac oscillation. If you see, there is a regular oscillation on this graph. So you have see these are the cardiac oscillations, and which when the cardiac oscillations are strong enough, it causes a change in the interthoracic pressure. And that can actually trigger the ventilator, especially if your sensitivity is kept as high. So that's a cardiac oscillation. You can see, in this picture, you can see actually a larger variation in the pressures and the flow. So this is another factor, the cardiac oscillation. We'll see how it actually increases the respiratory rate. So this is a patient on a ventilator, but he's connected to a monitor which has the enteral carbon dioxide here. And this is the breath rate, and now the set rate is about 9, and that is the expiratory phase. When you have so let's run this video, and you see it doesn't change. Okay, that is the exhalation. So this is how this graph goes, and there is no extra waves here. So the ventilator ventilates correctly. And now the next one, if you see, we have actually increased the expiratory time. When you increase the expiratory time, like this, people who are anesthetists will recognize this waveform. You have the cardiac oscillation, and the EtCO2 actually starts coming in waves, small waves. And if you look at the respiratory rate here, you see slowly the rate is increasing. So this cardiac oscillation is actually triggering the ventilator. So this again is a false trigger. So cardiac oscillations, secretions, and sometimes air leak also can trigger the ventilator. So now we have seen a condition where the patient actually is not breathing, but the ventilator is getting triggered. Now the second one is there is a failure to trigger. So the patient is actually making an effort, but the ventilator is not able to deliver a breath. So if you look at the expiratory waveform here, you can see concentrate on the dark green line, the downstroke. You can see normally the dotted line is the course of the expiratory flow, but then you can see when there is an upstroke, it usually is an indication that the patient is actually breathing, an active inspiratory effort. So this is happening very close to the soon after the expiratory flow has started. So this is what we call an early cycling. Okay, this is early cycle. And then this is not strong enough. If it was a bit strong enough, it would go and trigger the ventilator, but it is not strong enough. Again, there is one more attempt by the patient, which is actually not followed by a breath, but here a breath is being delivered. So this is what we call a failed trigger. This may be because of a very low effort from the patient side, or some factors like auto-PEEP, etc. So if you look at this, when you come to the auto-PEEP, this is a chance to see how we do the auto-PEEP also. So this is a patient on a SIMV mode, volume control mode, and we suspect that there is an auto-PEEP based on the expiratory flow not touching 0 here. We have a very high respiratory rate also. So I'll run this video. And so now expiratory maneuver has been activated here. Now what has happened is So if you see, my set PEEP is 5, but my auto PEEP is about, total PEEP here is about 11.6 centimeters. So I have an auto PEEP about 6.6 centimeters. Now, if I set my pressure trigger at 2 centimeters, my PEEP is 5. So normally the ventilator will get triggered when the pressure drops down to 3 centimeters outer. So from 5 centimeters, when the pressure drops down by 2 centimeters to 3 centimeters, the ventilator will get triggered. Now my PEEP has gone up to 11.6. Okay, so even in this situation, my pressure has to drop down to 3 centimeters, which is 8.6 centimeters for the ventilator to trigger. So this patient will find it difficult to trigger, and you'll see failed trigger in such situations where there is auto PEEP. This auto PEEP can also happen when there is large tidal volumes, excessive support. So after we have completed the trigger, the next is the limit. So what all can happen during the limit? The patient may not get adequate support from the ventilator. And so the ventilator does not go into the expiratory phase, and the patient triggers the breath again. So this is what we call a double trigger. So this is called a double trigger. The trigger happens before the expiratory flow is complete. So this is a classical double trigger where the patient's inspiratory time may actually be longer than the machine inspiratory time, or the patient may not have been delivered adequate tidal volume, or the patient may not have had an adequate flow. So he takes another breath. So if you see here, the pressure actually drops down. The expiratory flow is not complete. Soon after this breath, another breath is taken, and this actually doubles up. So what happens in this double triggering is the tidal volume can become large, and that can become injurious to the lung. So we talk about low tidal volume ventilation. When a double trigger happens, and when both the breaths are delivered fully, the tidal volume becomes huge, and that can actually cause lung injury. So this is a graph you see. There are these short ones are kind of regular breaths. So we set up tidal volume of 500, but then here the patient has a double trigger. So if you see here, it triggers here, and the airway pressure goes up, and the total volume, if you see, has increased, is gone up to 757 ml. That is almost 50% more than what you want to administer. So this kind of large tidal volumes can become injurious to the lung, can cause barotrauma. So this is what we call double triggering. The next is what we call this is the fail triggering. We can see what you see in the flow. We can see the flow starvation, exactly very similar to the double trigger. See the flow starvation, where the patient is not receiving the flow matching his needs. So this patient is actually on this adaptive support ventilation, which is kind of an automatic ventilation, which will adjust your pressure support accordingly. I'll run this video. You'll see what I want you to observe here is here. I'll bring it back a bit. Here, if you see this graph, so there is a breath delivered, and you can see the patient is actually making another attempt. Okay, towards the end of the breath, is making another attempt, and this here is attempting again. As I said, any upward deflection is suggestive that the patient is actually taking a breath. So there is an upward deflection, but he's not able to trigger. So this is again a failed trigger. He's not able to trigger, and there is some amount of flow starvation. So he's trying to take another breath. This again is a failed trigger. So when we move across this video, we'll see what happens. And I also want you to observe that the pressure support here, this is an adaptive support ventilation. So all the breaths are taken by the patient. The breath rate is about 17. And you can see the inspiratory pressure is 10, which means there is a 10 centimeter of pressure support. And as we go along the graph, I want you to see what happens to his tidal volume, what happens to his respiratory rate, and also what happens to his pressure support. So now that's not adequate. So he's triggering, and all the breaths are being triggered. And you can see that what you would have observed is, I'll just move the graph a little behind. And you can see the pressure support actually has gone up to 14. Since respiratory rate has gone up because he's not getting adequate support, the ventilator automatically increases the pressure support to 14. From 10, it has increased the pressure support to 14. And with time, you will see that his breathing actually settles now. You can see the rate actually comes down, and still there is some amount of starvation. Is still, so with time, it will increase the pressure support more, and the ventilator will settle with the patient's effort. So this is what there's a failed trigger, and because of inadequate tidal volume, inadequate flow. So the ventilator automatically adjusts the pressure support upwards, then bringing back the tidal volumes up, and the respiratory rate actually settles. So increasing the pressure support may be one way of settling that, flow starvation, or sometimes you may have to increase the inspiratory time. So this is another typical thing we may be able to see here. What you see here in this is, the top one is the volume to time. This is again a video, I'll run it, it will be clearer. So this is a flow to time, and this is the pressure to time. What I want you to observe is that the expiratory flow is actually running parallel, right? It is usually at an exponential, it goes like this, but it is running parallel to the x-axis and all this. And also the patient is actually has to take deep breaths. It's almost touching from PEEP, it is almost touching 0 before the ventilator is getting triggered. So you can see that very clearly, that this is not actually exponential. This is actually a patient who has an endotracheal tube which is blocked. Okay, in this situation also, he may not be able to trigger effectively. And so if you disconnect the patient from the ventilator, this is what you see. You get a paradoxical breathing. So you can see the paradoxical breathing. You never will be able to wean this patient. We actually exchange the tube for a new tube, and that sorted out the problem. So this actually can lead to trigger synchronies also. So next we are coming to the dyssynchrony, which is a mismatch between patient demand or need and the ventilator response. So the patient may actually need more, the ventilator is not able to provide, or the patient needs less and the ventilator is giving too much. So it can be from the cycling perspective. This could be the time, flow, or pressure related. And the patient will have his own inspiratory time. The machine will have its own inspiratory time. So there may be a mismatch between the patient inspiratory time and the machine inspiratory time. So this all can lead to dyssynchrony. So let's talk about the cycling. The cycling can be, a long cycling. So when you have a long cycle like this, which means that the patient actually wants to breathe out, but the ventilator is not cycling to exhalation. So in this situation, you see what happens is there is a spike. If you see this pressure waveform, so that is the onset of inspiration, pressure goes up, that's a plateau pressure, and then it spikes before it goes to exhalation. So this is a very typical scenario where the patient's inspiratory time is actually shorter than the machine inspiratory time, and we have to do something about reducing the machine inspiratory time. So how do we reduce the machine inspiratory time? We can go into the the expiratory trigger sensitivity and reduce it, or you can even reduce the pressure support and see. In this situation, we actually reduce the adjusted the expiratory trigger sensitivity from 10% to 30%, and then that sorted out the problem. You can see the spike is gone and the pressure actually has come down. You can sometimes the pressures can go markedly up, and which can be injurious to the lung. So if you see a spike in that expiratory towards the beginning of expiration, it means that the inspiratory time for the machine is longer than the patient's requirement. So you do whatever is necessary to reduce the inspiratory time. The next is the flow. So it could be early cycling, as we see. So this is the typical expiratory flow form. And here you see there's upward deflection, the same graph I showed you earlier. So the patient, this is the early cycling happening with an ineffective breath. And if the patient is actually breathing out, if actively exhaling, you will see this wave actually becoming convex down. Usually it is concave down, becomes convex down, which may be a sign that the patient is actively breathing out, which can happen in very high dose opiate sedation. So in this is a patient who is on NIV, and you can see that the respiratory rate is about 34. is on a pressure support of 15, PEEP of 7, and his tidal volume is about 273 ml. And you can see there's a lot of early cycling and failed triggering. So not all the breaths are getting triggered. So he is tachypneic. Let's move on with this video. So now that we see there is a kind of a early cycling and failed triggering. So clearly the machine is not delivering what the patient needs, and there was no leak at that point. So what we did was go into the settings, and you can see the problem here is the expiratory trigger sensitivity was set at 50%. When you say 50%, then you're going to have a very short inspiratory time. So in this scenario, we went ahead and increased reduced the ETS. We brought it down to 10. And now you see instantaneously, you will see that the tidal volumes get better, and slowly, the early cycling is getting better and the respiratory rate is coming down. So here there was an early cycling and a failed triggering because his cycling the ETS was quite early and the inspiration was getting cut off. The machine inspiratory time was shorter than the patient inspiratory time. So he has settled now nicely. He may need some more extra pressure support because there's still a little bit of early cycling here. So if we increase my pressure support, that may actually get better. So the third thing is here pressure. So what happens to the pressure? What is pressure cycling? How pressure cycling can affect the synchrony of the ventilator? So this is the alarm setting on the ventilator, and if you can see, we have set the alarm at high pressure alarm at 30 centimeters of water. So now I'm going to run this video. So here is a volume control ventilation. We are set to deliver 500 ml tidal volume, and the tidal volume delivered is about 493 ml. And my peak pressure here is 28 centimeters of water. And remember, we set the peak pressure limit as 30 centimeters of water. Let's see what happens here. Keep an eye on the tidal volume and the airway pressures. So, so you can see that what is happening here is the tidal volume the airway pressure has gone up to 30 centimeters. Airway pressure has gone up to 30 centimeters. The moment the airway pressure goes to 30 centimeters, the tidal volume starts dropping. You can see the inspiration is actually become shorter. So this is pressure cycling. So when the pressure cycling also can affect the synchrony between the ventilator. This patient is actually very deeply sedated, so he is not, he's not responding to that. But if he's lightly sedated, he is very likely to become tachypneic because his demand is not being met. So these are the two graphs we saw. So this is the settings where we had a 500 ml tidal volume and we had the peak pressure of 28. And once the peak pressure went up, you can see there's a drop in tidal volume and the inspirator time, the breath has become very short, and that can lead to dysynchrony later when the patient becomes more awake. So there's another phenomenon called reverse trigger. Reverse trigger is a phenomenon where the patient actually does not take a breath. The machine delivers a breath. And once the machine delivers a breath, the patient takes, that stimulates the inspiration of the patient. So in this graph, you can see on the top, this is the pressure to time, the flow to time in the middle, and the volume to time. You can see the first one, there is a breath. Okay, the pressure has gone up. So it's the pressure control ventilation, pressure control of 10, PEEP of 5. So your plateau pressure is going to be, peak of the plateau pressure is going to be 15 centimeters of water. So a mandatory breath is being delivered. But then correspondingly, you see very little flow and very little volume. But at the end of the breath, the patient actually, you see this pink triangle, the patient actually takes a breath. Okay, so his inspiration is stimulated by the previous mechanical breath, and a breath is being delivered, right? So again, here you see this one, there is a mechanical breath a mandatory breath being delivered, but very, very little volume going through, flow going through, very little volume going through. And the third breath, but this is not followed by a patient spontaneous breath, a second breath. But the third breath, again, you see it's very similar to the first one. So there is a mechanical breath, very little flow, very little volume, and the patient takes a breath here and that gets delivered. So this is what we call a reverse triggering. So this you can see in this video, as we progress, some of the breaths are being delivered and some of the breaths don't go through. And this may be a double triggering, right? So there's a breath has gone through and then he's taken halfway through itself, he's taking a breath and that pressure is actually touching zero. So this may be a case of a double triggering here. So there is, if you look at this, there is probably some amount of leak also. So this happens. Why is this mechanical breath is not going through? This happens in patients who are on high dose opiates. Okay, their intrinsic rate is very low and the muscle tone is increased and the breaths don't go through and they don't breathe also. I'll run this video again. From the beginning. I also want to show a feature of an active exhalation, right? If you see this curve, this is an expiratory curve, right? So we expect this curve to go up like that exponentially, but this is actually coming down like that. So this is an active exhalation from the patient. So this is a patient who had a high dose opiate sedation. And the mechanical breaths were hardly going through. Following a mechanical breath, he's taking is actually triggering a breath, which may be triggered onto either a pressure supported breath or a pressure controlled breath. So this is a typical of a patient who is having an active exhalation. If you see this, the anesthetist may clearly recognize when you induce a patient or give some, say 50 mics or 75 mics fentanyl before your anesthetic, actually the breathing becomes more active. So this active exhalation and increased muscle tone prevent any mechanical breath to go through and only the spontaneous breath go through, and it can cause what you call the reverse triggering. So now at the beginning of the presentation, I said having an esophageal pressure monitoring actually will help us to identify various dyssynchronies. Here we have flow, pressure, and the airway pressure and the esophageal pressures. So any deflection down is a representative of a patient effort. So in this picture, you can see the patient is actually in this one, there is a downward deflection. So that means the patient is actually breathing. So the machine is delivering. So this is all pressure supported, spontaneous pressure supported breath. So the machine is delivering, initiating a breath, flow is going through, and then the breath is with flow cycling, the breath is, the inspiration is over, expiration is triggered. And here you see again, there is a small upward deflection. And I said there's upward deflection is always representative of a patient effort. And you see a corresponding dip in the esophageal pressure, right? But so the patient is making an effort, which is reflected by the increase in the flow towards upward flow. There's also a small drop, but this is actually not followed by a breath. So this is an ineffective breath. So having an esophageal catheter will help us to identify patient effort. This subsequent breath is deep enough. Sorry, 1 second. Meeting with upper basement. Sorry. So the subsequent breath, you can see the patient effort has a good effort, and that has actually triggered a breath. So this is what we call the ineffective effort, or this could be an early. This may be a sign of early cycling with an ineffective effort. Here again, the second one, you see, this is a there's a drop in pressure, and that is actually delivered a breath. And in this second attempt, you see there is no breath here. This is a case of a double triggering where he is actually triggered just after this breath. He is again triggered, so which is reflected by the drop in the esophageal pressure. So there's a double triggering which is delivered a breath. So here, the first phenomenon we talked about is the auto triggering. Here you see there are two breaths. So this is the flow to time. This is the airway pressure to time, and there is a small drop in pressure. But correspondingly, you see there is no change in the esophageal pressure. So without any effort from the patient side, the breath is being supported. So this is what we call the auto triggering. So having an esophageal pressure will help us to identify the any dysynchronies very easily. And again, a similar picture here. So there's a delayed cycling where you can see the patient delayed cycling in the sense the inspiration is longer from the machine side compared to what the patient actually needs. And you can see here there is a flow, and you can see the pressure actually spikes. The inspiration actually ends here, the esophageal pressure. The inspiration ends here, the beginning of exhalation. But here you can see it is actually proceeding further. So there is a delay in the cycling. And here you have the double triggering. So the patient is actually having a longer inspiratory time, but the machine inspiratory time is short. So he's again attempting another breath here because he's needing more support. So this is a double triggering. And here there is a reverse triggering. So the patient actually is taking a breath here. And so a second breath is delivered soon after the first breath before the expiration is complete. Here you have the premature cycling. So the neural TA is what the patient inspiratory time. But here the ventilator inspiratory time is very short. So soon after that, the patient is actually taking another breath. So this is a premature cycling with what looks like a failed trigger. And this is again an ineffective effort. The patient is attempting to breathe, but there is no ventilator. This is the ETCO2. You can see the patient. This is the esophageal pressure. This one is deep effort. So there is a breath is being delivered, but this one is a very weak effort, and this is not followed by a breath. So this is again an ineffective effort. So the common cause of asynchrony and dysynchrony is too much of support. So if you are giving large tidal volumes or giving a higher pressure support, if you increase the minute ventilation, then the patient's effort becomes less, and there is a lot of dysynchrony happening. So as you see here, as the percentage of support increases, the patient effort actually decreases. The respiratory rate comes down, and we often see this when we are trying to change the patient from into a spontaneous mode. When they have been on SIMB mode, they take some time to initiate spontaneous breath because they have been probably at that time giving higher support than what is necessary. So here is also as the increase in the number of if you increase the support, the incidence of ineffective triggering also increases. So if you look at it, there is a high pressure support or high tidal volumes. It actually reduces the inspiratory effort from the patient, and it also so this all leads to wasted effort and a lot of asynchrony and delayed in weaning. Asynchrony actually is shown to increase the morbidity and mortality of the patient. So this is actually associated with a lot of comfort issues with the patient. So some of the patients the asynchrony may not only be with the setting, but also the level of sedation, level of anesthesia. We need to optimize all that. And so if you adjust the ventilator according to the patient's needs and identify what the actual problem is, looking at the waveform, and will improve the synchrony. And studies have shown that automated system like the adaptive support ventilation, which is available in Hamilton, and many other ventilator models actually increase synchrony and reduce the duration of ventilation. Thank you very much.
Okay. Thank you very much, sir, for the detailed videos, and your presentation was very insightful, sir. Thank you so much for sparing your time with us in this evening. And sorry for the trouble we gave you. Thank you very much, sir.
I should apologize. I mean, I thought I'm all ready, but the usual electronic glitches.
Absolutely no problems, and thank you so much, sir. And now we have come to the end of this session. I sincerely thank all the speakers of today for giving us and sharing their knowledge with us and for giving us their valuable time. Thank you so much, sir. And thank you all the participants. And sorry for the inconvenience in between. And meet you all tomorrow for the 4th day of the SKS SIP program. Thank you so much.
So there are no questions, is it? Or is it we have run out of time?
Yes, sir. There are not many questions here, sir. Anything we'll get back to you, sir. We can discuss it.
Okay. Thank you.
Thank you so much, sir. Thank you, sir.